Very good morning. I know the topic is very well known to you all, that how do you manage your patients day in and out. When Dr. Seema gave me this topic, I said it's tough for me to talk in front of the audience here. And I'll try and do some justice to this. We know that, I think there is some problem with the slide. Is that the right slide? Anyhow, so what I'm going to talk about is why there is a need for anticoagulant in liver disease. What are the prescribing pattern, word over, prophylactic, therapeutic, what are the current recommendations from various societies, what are the risks we have when we use these agents, what is the anticoagulant agent you should be using, and what is the way forward. We all know that liver disease is problem of bleeding and thrombosis going on together. We know that there is bleeding because of platelet, because of the coagulant factors deficiency, or because of tissue plasminogen activation, because of increased fibrinolysis which is going on. On the other hand, we find that there is a problem von Willebrand factor, coagulation factor deficiency of protein C, and antithrombin, and decreased plasminogen level. So whenever a patient comes to you in your emergency and he's bleeding and he's critically ill, he's intubated, the first measure we do is try and correct his bleeding. That do we really start anticoagulant in that patient? I would say 10 out of the 10 times we don't start. We just wait for this thing to settle, which would occur in next 24 hours if the proper care has been taken for settling the bleeding. But despite the platelets being low, INR being high, can this patient be put on anticoagulant? That's the question which is still difficult to answer. So many physicians earlier used to think that there is auto anticoagulation, so why use these therapies in these patients? But most of the studies now have proven that this is not correct. And there are hyper and hypocoagulable states which are present simultaneously in these patients, which may lead to these processes. So one of the studies done for here where they showed that there was imbalance between procoagulant and anticoagulant factor of factor 8 and protein C ratio, and that was statistically significant. So why do we need prothrombotic? Why do we need anticoagulants? We know that this is a prothrombotic state. There is high incidence of venous thromboembolism in these patients of DVT. When the patients of cirrhosis are hospitalized, we know that PVT is quite common in cirrhotics, and now even in NASH and all other chronic diseases with chronic dysfunction of liver, you have independent risk factors. And in fact, in this category of patient, there have been an incidence of VT and DVT to the tune of 3 to 4.1% in various studies. And primarily because these patients are left immobile because of the muscle wasting and encephalopathy and ascites. And so we should consider these patients who are hospitalized for thromboprophylaxis. However, the large-scale studies in these are still lacking. So there are these questions: is this prophylaxis indicated in hospitalized patients with cirrhosis? Should they all be screened for non-tumoral portal vein thrombosis? What are the specific data for anticoagulant therapies? And if patient has atrial fibrillation and cirrhosis together, we do start anticoagulant. What should be the choice? What should be done? Is it safe and effective? We don't have to test for hypercoagulable state in each and every patient. You do it only when you have these thrombotic states in unusual locations, or you have a strong family history, or you have some suggestion of a myeloproliferative disorder, or something like PNH, or all those in these patients. So do not go for testing in all these patients. What we do is that we start testing them when they come with already an existing thrombosis somewhere. So what is the need for prophylaxis in cirrhotic patients? Very small study in 2012 in gastroenterology, which included around 180 patients. They looked for efficacy of prevention of PVT, and they found that there was not only a survival but also in terms of decompensation benefit in these patients. But this was a very small, and patients were child class A primarily. A study meta-analysis in 2012 in Canadian Journal of Gastroenterology showed that there is no doubt that there is increased risk of VT in these chronic liver disease patients. It varies from 1.8 versus 0.9% in controls. Again, in 2.06 for liver cirrhosis and 2.104, so equal in terms of patients with cirrhosis or no cirrhosis. So there is no doubt, and what was observed in this study in 2018 that these patients with cirrhosis due to NASH, which I was talking about, find that this NASH is an independent factor in terms of risk for pulmonary for PT in these patients. So this also has to be taken care of. We do use some scores, the Padua prediction score or other scores to calculate. So the same can be applied to these patients with cirrhosis. Although these were developed for all critically ill patients, the number of patients included with cirrhosis in these patients was minuscule, but same can still be considered to be applied in these patients. So one of the earliest study in which I was involved in 1999, published in NEGM, MedNox study, where critically ill patients who were in wards, not getting ICU, do we use a thromboprophylaxis in them or not? So we tried to use 3 models, 40 milligram of enoxaparin, 20 versus nothing, and we did find that there was a significant difference in outcome in these patients who were immobilized in the wards or in SDU. And that is the genesis when people started thinking of using a prophylactic anticoagulant in patients who are critically ill. Another study published, and subsequently when they did a meta-analysis of various ICUs in Europe, they found that still there is a lot of reluctance in using, even in patients who are in ICU, and primarily because high risk of bleeding or ongoing bleeding, or probably an invasive procedure is upcoming, or there is limitation in life support. They have given DNI, but in almost 20% of the patient, there was no reason given why it was not started. So there is primarily a reluctance on part of treating physicians about this. So despite the other controversies, that despite we give adequate thromboprophylaxis in these patients, we do continue to get VTE. Now, if you analyze these patients, there are category of patients who have high BMI or have family history or personal history of VT. They or those who are receiving dual or triple vasopressors. These are the category, despite prophylaxis, might get VT, but not all. What was observed again in a paper which analyzed why liver patients are not getting much of the anticoagulation, it was because of the concept that they have thrombocytopenia, and that's why the prescribing prevalence was almost 40% less in patients for anticoagulant and 20% for antiplatelets in these patients. And when you looked at 1 year, it became 50%. Surprisingly, maybe there is some bias here, the analysis showed, we know that NOACs have now come and they are being used. So when they looked into a small number of patients with cirrhosis who were getting NOACs, they found that the patients who were taking that continue to stick to that, despite any valid evidence of prevention of bleeding and all that. So we know that if they have atrial fibrillation, yes, we should give them anticoagulant to prevent stroke, and but there is definite benefit over only giving antiplatelets. There is no benefit of giving only antiplatelets to these patients. You have to give anticoagulant. And there was no significant difference in hemorrhage in these patients. What does ACCP, American College of Chest Physicians, recommends? That evidence of VT is similar in patients with cirrhosis as with other patients. And there is certainty, although low certainty of evidence of increased bleeding risk with pharmacological VT prophylaxis, but still this is recommended as a conditional use. We know that what happens of portal vein thrombosis and cirrhosis, which is either causing decompensation of cirrhosis, or it is happening because of this because of cirrhosis, PVT. We know that there is spontaneous resolution in almost 47%, 31 to 70%, regression in 47%, and progression is only in 7 to 8% of patients. So do we put every patient to risk by giving them thromboprophylaxis when the progression is only in a small number of patients? But the question is, how many of them are symptomatic and how many remain asymptomatic, and we pick them up. So this is a recent paper in Journal of Hepatology where they looked into various factors which led to predicting whether thrombosis will occur in cirrhosis, and they had around 340 patients. They had 369 patients. Out of that, only 29 patients developed PVT over a period of 14 months. What they looked into, and they found that acquired or inherited hemostatic disorders as well as inflammatory state did not predict the development of cirrhosis. So these were not the cause for development of cirrhosis. What they found was low flow in the portal flow. So many of those patients who come with PVT may not be having PVT, they may be having low flow in the portal veins. The liver disease and severity of portal hypertension, low platelet count, low albumin, large varices and previous sclerotherapy, previous liver decompensation or presence of large shunts, and use of non-selective beta blockers. They may play a role in development of PVT. So in patients with cirrhosis, factors predictive of PVT were mainly related to severity of portal hypertension rather than anything else. Other study which was predicting the risk of portal vein thrombosis, they looked into some markers. So there are many studies, I have taken just one. When they looked into this marker, they found that persons having this may develop portal vein thrombosis in a period of 6 to 12 months. But these results cannot be generalized due to a small sample size. The study which being done here, I think partly completed by one of the SR here and talked about, I think, a couple of months back, where they tried to randomize these patients of cirrhosis. Look at the large number had to be excluded and the dropout. So finally they got these number of patients, and they found that using anticoagulants in these patients does help in terms of regression and resolution to the tune from 42 to 82%. So there is no doubt, there is evidence that this is useful. There are other studies of anticoagulant in these patients, like patients who were undergoing EVL, patients who had either on low molecular weight heparin or low molecular weight heparin, patients who had some of these risk factors in terms of large varices or underlying portal vein thrombosis or high creatinine. They were between bleeders and non-bleeders. These were the differences. So what happened in these patients? Equal number of patients succumbed to the illness. So there was no difference in terms of mortality despite these patients being put on low molecular weight heparin. So it does not increase the risk of any post-procedural bleeding. So if your patient warrants this, you should go ahead with prophylactic therapy after the EVL correction. One of the meta-analyses published in 2021 about anticoagulation favoring thrombus recanalization and survival in patients with liver cirrhosis, they looked into around almost 529 papers, 1,461 papers, and out of that finally they selected only 33 papers because many of these patients were not meeting the strict criteria of prescribing therapy for thrombosis. What they found was that overall portal vein recanalization was significant in patients who received. So with a confidence interval, you can see 2.61. Similarly, the complete was also significant, 2.1, and even thrombus progression reduced to significant level in these patients who received therapy for 6 months to 1 year. They also found that what was the overall bleeding in these patients, upper GI or other bleeding, and they found that there was significant difference in terms of bleeding. So there wasn't increased risk of bleeding in these patients who received anticoagulants for a long period of time. And even death due to bleeding events, marginally little higher, that's all, but there wasn't much difference, almost equal. And the overall survival, so that is the bottom line. So generally we find that the overall survival does not increase in most of these patients. And that was the observation that they found, that overall survival was equal in both the group of patients receiving anticoagulant and not anticoagulant. 1 year survival 3-year survival and 5-year survival. So there was not much difference. So why give them? The question is, why give them? We give them because we prevent repeated decompensations. We want to prevent repeated hospitalizations and look into little better quality of life. So what we ensure with this study is that you should have adequate prophylaxis prior to starting anticoagulant in these patients. Better if you start very early. Try and exclude B and C and high MELD. So most of the studies included patients with MELD score below 20. So they were probably early cirrhosis. Survival benefit analysis you have to do, and probably you need to develop a score based on which you would try to anticoagulate these patients. As far as the direct oral anticoagulant which are now being used, one of the paper which looked into that aspect did find that the recanalization rate was high for those receiving. Even the progression was only 9% versus 33%. The recurrence of thrombosis once it was stopped was almost 38%. There was poor response in high MELD and decompensated. Only 5% bleeding rates in 257 patients on anticoagulants, and one may expect similar outcomes with NOAC. So these were all involving low molecular weight heparin and oral and vitamin K antagonist, warfarin. So you did. So what are the current practice guidelines from AGA? It suggests that is VTA prophylaxis required in all hospitalized patients with cirrhosis? Yes, it does suggest that one should use that, but the recommendation is conditional, but the evidence is very low level. What, if any, specific anticoagulant therapy is given in these patients with subacute non-tumoral PVT? Yes, it should be given. However, the evidence is still low. Should patient atrial fibrillation and cirrhosis be treated? Yes. Again, the evidence is still low. The ASLD and ESL, I don't need to go into detail, you all practice this, but very interestingly, it says that you divide in patients with ASLD with, you give them anticoagulants plus local or systemic antithrombotic if there is an acute onset of PVT. Case-based, if small, less than 50%, then review every 3 months, don't start straight away. If more than 50% main PV or mesenteric vein thrombosis, anticoagulant should be given. Chronic PVT anticoagulants plus TIPS. However, ESL says that for chronic PVT anticoagulants after adequate prophylaxis for GI bleed and anticoagulation at 6 months, for 6 months in these patients with acute PVT, and also if there is evidence of any ongoing intestinal ischemia. After liver transplantation, no recommendation, it is case-based, so we know that many patients before transplant, if they have PVT, the outcome after the transplant is likely to be poor. So there are some varying recommendations, but it doesn't, the ESL still doesn't talk about NOACs. The ASLD suggests that yes, NOAC can also be used. Also in patients with hepatic vein thrombosis and Budd-Chiari, there is no doubt you have to use anticoagulant. Initial year, the NOACs, when they were used in these 3-4 trials, they were only for non-valvular AF. That was the only recommendation which came in 2014-15, and no other indications were there, and there were no patients looked into whether they had underlying chronic liver disease at that point of time. So we now know that we have these molecules available with us. What is their mechanism of action? I will not delve into all that. You all know that. But what is important is that the dose convenience is there with many of these NOACs. You don't have to monitor INR like you have to monitor in VKA, and INR may be unreliable in these patients. But the problem is about renal and hepatobiliary clearance. So except dabigatran, others have little bit more hepatobiliary clearance like apixaban, rivaroxaban almost to the tune of 40%, so you have to be cautious. No overlap is required in most of these NOACs. We have to be careful when the CCR is less than 10 to 15 in most of these. Even in warfarin, there is no contraindication as far as the CCR is concerned. And for liver disease, most of the studies still have less experience, less evidence in terms of using these NOACs. and it's been clearly said that don't use them in CTP B and C or advanced liver disease. We know about this. I've already talked about, but the good part is that we now have antidotes available for most of these. So if at all there is a serious bleeding, it can be reversed. The drawback of the traditional anticoagulants I will not touch upon, because you know most that with unfractionated heparin there may be a decrease in this because of low level of antithrombin synthesis by the liver. You have to give every day an injectable form. That's not easy. Limited use in concurrent renal impairment. You will have to use a conventional heparin here. And elevated INR can offer a false measure of therapeutic efficacy of VKA. And again, protein C and vitamin K dependent anticoagulation factor is reduced in cirrhosis and may decrease the efficacy of these VKAs. And they have a narrow therapeutic window. So there are issues with oral anticoagulants we use. There is no doubt that in patients using now this study where they use NOAC in patients with cirrhotic patients with non-valvular atrial fibrillation, they found excellent result in comparison to warfarin. These are some of the studies where they looked into patients with PVT and all that, and they found that there was resolution of PVT, less major bleeding in DOAC group, also isolated reports of minor and major bleed in these patients using NOACs. And if you look into the recent studies published in 2020 and 20, where they had small number of patients, but they did find better resolution in terms of 85 versus 45% in rivaroxaban versus warfarin. Also, recurrence rate was only 4.5% in these patients. Here again, endoxaban versus warfarin, 70% versus 20% better resolution, and rate of progression also delayed significantly. The study, so the challenges with NOAC we have is the clinical experience with them is still limited and confined to small compensated cirrhotic patients. Most are retrospective studies. There are only 2 prospective studies involving hardly 60 or 70 patients. Concern about efficacy in decompensated when thrombin generation is measured is reduced. However, the use is now expanding in patients with atrial fibrillation, VT, and portal vein thrombosis. Availability of direct reversal agents should allay the fear of bleeding reversal. The role of DOAC on fibrosis and portal hypertension is suspected but not proven as yet. There is another study where 133 patients with advanced liver disease were given NOAC. A significant number of them had bleeding, 28% during treatment, of which 23 were graded as major. Major spontaneous bleeding was seen in acute ACLD patients with CTP-BC, but not with having hepatocellular carcinoma or varices. So you have to be very cautious while using it in advanced liver disease. And when you looked into persistence of these prescription in these patients in meta-analysis, you found that either apixaban, rivaroxaban, or warfarin, the persistence of use at 6 months, at 12 months was equally similar. And in fact, it was little better in patients who were taking NOACs in comparison to warfarin. Whether antithrombotic therapy in patients with liver disease, when they looked into this persistence and adherence, they found that once a day regimen does improve adherence. NOACs have a shorter half-life and less reliable on hepatic clearance, especially dabigatran. However, rivaroxaban and apixaban may need hepatoclearance, renal clearance, and cytochrome P450 metabolism. So in patients with coexisting liver and kidney disease, you have to be cautious. They also have high plasma protein binding capacity. So increased free drug levels when albumin is low in these patients is to be taken care of. And selecting DOAC with antidotes available may help mitigate some of these. To summarize, I would like to say that we need standardized classification definition for PVT and spontaneous resolution. We do not have that still. PVT is common thrombotic complication with poor outcome. At least 6-month therapy, however, recurrent thrombosis would continue. So after 6 months, what are the recommendations of various guidelines or ESL where they say after 6 months you can stop? You have to think again, can we do that? There is definite efficacy and safety of NOAC seen in small studies, mainly retrospective. They say appear safe and efficacious, but we do need study role of their role as prophylactic at high risk of PVT and at time of initiation, what is the time you initiated that. There are lack of convincing data regarding benefits, as portal vein regression may not improve the course of illness, as we showed that after 1 year the survival was similar in those given anticoagulant or not given. And we need prospective trials among NOACs to look for one with best efficacy and safety. So what is the way forward? I have not developed the algorithm. I should have done that. So should we replace, which we probably do more, that tag rotem should be used in a patient coming to your emergency and do an immediate correction. And if he's ventilated, he's confined to bed, you may use mechanical prophylaxis, but do you think you need to use a pharmacological prophylaxis? Primary prophylaxis, you have to be very cautious. Do we look for more markers, biomarkers to preempt thrombosis? Can NOAC replace warfarin? Probably may in years to come, but more and more evidence, because more and more evidence is now generated about its safety in liver disease. So select your patient with liver disease with caution for anticoagulant therapy. Advanced liver disease, you all know, will have risk of bleeding, and you need prospective studies, and I hope that the study dabigatran, which is ongoing here, when it will include more than 300-400 patients, would throw some light on what happens in them. Thank you very much for your patience here.